This is the beginning of pharmacology stories, but before we can jump into actually looking at medications, we have to know how the body interacts with drugs and how drugs interact with the body. So we're going to start with pharmacokinetics, which is the study of drug movement throughout the body, or in simple terms, basically what the body does to the drug. And this has 4 key processes. So we have absorption, distribution, metabolism, and excretion. Absorption is the drug moving from the administration site into the blood. Distribution being the drug moving from the blood into the tissues and cells, and metabolism being enzymatic alteration of drug structure, and this often happens in the liver. And excretion is elimination of the drug or the metabolites from the body, mainly via the kidneys. So first, let's talk about how drugs cross membranes. So drugs have to cross the cell membranes, and this usually happens through the cells, not between them. So you can have lipid-soluble or lipophilic drugs, and those will cross easily just through the membranes. But polar drugs and ions cannot cross cell membranes. So they have to utilize transport systems, and these are very selective. So for example, when drugs, very few drugs can cross the blood-brain barrier because the transport system is so selective. So first, let's talk about absorption. So absorption is movement of the drug from the administration site into the bloodstream. Rate of absorption determines the onset of drug action, and the amount absorbed determines the intensity of the effect. So there are 5 main factors that will affect absorption. 1 is the rate of dissolution. So the faster rate equals quicker absorption. 2 is the surface area. So the greater the surface area, faster the absorption. 3 is blood flow. So greater blood flow, faster absorption. 4 is lipid solubility. So the more, goes with crossing the membranes, the more lipid soluble a drug is, the faster it will be absorbed. And then 5th is pH partitioning. So the ionization differences enhance absorption. So the greater the ionization differences, the better the absorption. So some common routes of administration. 1, we have oral, commonly abbreviated to PO. So some barriers to oral absorption is the GI epithelium and the capillary wall. Obviously, that's what the drug is going to have to pass through to get absorbed into the bloodstream. Oral absorption is affected by drug solubility, GI pH, food, other drugs, special coatings. Some advantages of oral administration is it's easy, it's safe, patients can do it at home, so it's very convenient that way, and it's also reversible. So you take too much of a drug orally, you can get your stomach pumped, or you can reverse it with activated charcoal, stuff like that. So it is safer that way. Some disadvantages, though, are variable absorption. So not every body is going to absorb the same amount of the drug. So say you had 81 milligram aspirin, someone might absorb that, more of that drug through their stomach than another person. So it's very variable that way. And also some drugs become inactivated by stomach acid, and so that can be obviously a huge disadvantage there. And also, you need a cooperative patient. You need a patient that is able to adhere to the medication schedule, especially if they're doing this at home. There's no way of doctors or nurses to track that, and so you have to trust the patient, and you need to know that patient is going to take their drug. Or if they're at the hospital, you're giving them this oral drug to take, and you're trusting that they're actually taking it, and they're not going to fight you on this. So again, patient needs to be cooperative. You have something called, with oral administration, the first pass effect. So drugs pass through the liver before entering systemic circulation. And so there, we briefly mentioned it before, the drugs can get metabolized. So they may be inactivated, and only a little bit of the actual drug amount enters the bloodstream. So that's called first pass effect. You also have something called enterohepatic recirculation, where the drug cycles between the liver, bile into the intestine, into the portal vein, back into the liver, and it just kind of goes around in like an endless cycle. So that's also important to note. So another route of administration is parenteral or injection. So you have a couple different options when doing injections. You can do IV. So there's no absorption barrier with IV, right? It's intravenous directly into the vein. So it's immediate and complete. There's rapid onset, precise control. So it's very helpful in that way if you need to get something right into the bloodstream. The only thing with that is if it's entering right into the bloodstream, it's not going to be reversible. So once you administer that medication, there's no going back. There's also risk for infection or embolism, as with anything that you're injecting into the body, into the blood, can cause adverse reactions there. Another injection is intramuscular or IM. So the capillary wall is the barrier there. And what's helpful with IM injection is that you can use something called depot preparations. So this is when you inject the drug or the medication, and a depot preparation is a slow release. So it kind of just, you slowly get the effects over time. It's not all of the medication all at once. And so that's very helpful with IM. Common IM would be, these aren't depot preparations, but when I think of IM, I think of like, you think of like your vaccines, stuff like that. That's all IM. If you ever talk about like naloxone, that's an intramuscular drug. So yeah, just directly into the muscle. Some downfalls to that is it's painful. I mean, you're injecting right into a muscle, so it is going to be painful, and there can be tissue injury as well. And then sub-Q, which is kind of the same kinetics as IM. It's going into the kind of like the fatty tissue, often like the back of the arm or the stomach or the kind of like the upper glutes. And so, yeah, you can, the barrier there is the capillary wall. Again, it's painful. There can be some tissue injury. With sub-Q, there's not so much depot preparations, but you can have like a catheter, so you can continuously administer sub-Q. Some other routes. You can also have topical, inhaled, rectal or vaginal, or direct injection. So topical would be like onto your skin, your mouth, rectum, can be local or systemic. So if you think of like transdermal patches, creams, stuff like that, that's all like considered topical. And then you have inhaled. So like when you think of like like inhalers. So like for asthma, that would fall under inhaled. So it usually causes just local lung effects. Rectal or vaginal, so like suppositories, and these can also be like local, or they can have systemic effects. And then direct injection, these would be like directly into like the heart or the joints or the nerves. So like if you think like a cortisol shot directly into your joint, that would be, again, direct injection. Okay, so now we're going to talk about distribution. So distribution is the movement from blood into the tissues and cells. And there's some factors that affect kind of distribution. So obviously blood flow to the tissues. If you're not getting good, because the drug's coming from the blood and is going into the tissues, so if you're not getting good blood flow, the drug won't be going into the tissues. The ability to exit the vascular system, so to go from the blood into the tissues and cells, and then ability to enter cells. So when we think of exiting the vascular system, typical capillaries, so we're going to talk about some distribution methods here. So typical capillaries, drugs just pass through the pores. It's easy peasy. But then we have the blood-brain barrier, and I kind of mentioned that it's very selective, so there's tight junctions, and only lipid-soluble or actively transported drugs can cross. So we have the PGP pump, which is the P-glycoprotein pump. And what this does, it's a protective mechanism for the brain, and it pumps drugs back into the blood. So basically, say a drug tries to enter the brain and the brain's like, no, not having it. The PGP pump will pump it back into the blood, and it won't actually get distributed into the brain, which is a great protective mechanism, but it also makes it difficult when we want to get drugs into the brain to treat neurological issues, and we can't because the blood-brain barrier is so selective. When we are thinking about other ways of exiting the vascular system, we think about placenta. So when you have a fetus, much of what the mother takes gets passed on to the fetus because lipid-soluble and non-ionized drugs cross. However, polar, ionized, or protein-bound drugs do not. So when I'm talking about protein-bound, what I mean is drugs bind to proteins, mainly albumin, and then the bound drugs, they stay in the bloodstream, so they won't be distributed. And what that equates to is a longer half-life, so the drug will be in the body longer, but it will also have slower action, so slower onset. And when entering the cells, this is required for metabolism and excretion, and when entering the cells, it needs to be lipid-soluble or utilize a transport mechanism. Okay, metabolism, or sometimes this is referred to as biotransformation, but often it's just metabolism, how's the drug metabolized? So it is the chemical alteration of the drug structure, and this commonly occurs in the liver. Later on, we will talk about some that occur elsewhere, but it is commonly the liver. So we have hepatic enzymes, and these are performed by the P450 or the CYP enzyme system. And there's a lot of different types. I'm not going to get into them, but you can have CYP1, CYP2, CYP3, and they all will metabolize, between the four of them, or the three of them, they will metabolize most drugs. But besides knowing, you don't really need to know the different, at this stage anyway, the different CYPs and what they do. Just know it's the P450 enzyme system. So, what metabolism causes? Accelerated renal excretion, drug inactivation, increased effectiveness, activation of prodrugs. So prodrugs are drugs that remain inactivated, or basically just not useless, but just floating around in the body until they hit the liver and they get metabolized, and then they become active. So when you hear the term prodrug, that's what it's referring to. And then it can increase or decrease toxicity of a drug. So when I mean renal excretion promotion, liver will convert lipid-soluble drugs into hydrophilic drugs. And this will make it easier for the kidney to excrete. So this process is called glucuronidation, something like that. And basically, it's a simple structural change. So it attaches a polar group, making the drug hydrophilic, and therefore the kidney will be able to excrete it. So across the lifespan, metabolism isn't equal in ages. So we have to consider where a person is at. And again, everybody's going to metabolize differently depending on their liver function. So some special consideration is obviously age. Infants and young children have a very immature liver, so they're unable to metabolize that drug as much, which can cause drug buildup and then toxicity. Same with elderly, they have a decreased metabolism, so again, slower breaking down of that drug will mean that it has the potential to increase in levels. Enzyme induction and inhibition. So inducers increase metabolism, which decrease drug levels. Inhibitors decrease metabolism and increase drug levels. So if you want a big drug effect, you would take inhibitors so that your metabolism decreases and you can maintain your drug levels. But if you want to get that drug out of your body, you want to induce metabolism, which will decrease the drug levels. And then we kind of already talked about the first pass effect, which is the rapid hepatic inactivation of oral drugs. So then it would be increased metabolism, reduced drug level. Another thing to consider with drug metabolism is the competition of being metabolized. So if drugs share a pathway, it will slow the metabolism of one or both. So if they're both being metabolized by the same pathway, you have to take into account that it'll be metabolized slower, meaning you will have increased drug levels. So you don't want to be overdosing on that drug because it will cause, you'll build up accumulation of the drug and you can get toxic effects. And then we have excretion. So this is the removal of drugs or metabolites from the body. So we can have renal drug excretion, which is the main form that we'll be encountering in this course. Most drugs are excreted renally by the kidney. So there are kind of like three main steps. One being glomerular filtration. And these are the unbound drugs being filtered into the urine. So if you think of a nephron, it's kind of like that first big vascular chunk when the unbound drugs. So remember, if a drug is protein bound, it won't be filtered. And these are filtered into the actual nephron. And so then we can have reabsorption and secretion. So then we have passive reabsorption. So lipid-soluble drugs are reabsorbed and they would go back into the bloodstream. And so this is important when we were talking about glucuronidation. These would create hydrophilic drugs, so they won't be reabsorbed, which is what we want. We want the ions and the polar drugs to be excreted. And then we can have active secretion. So like we were talking about the PGP pump in the brain. We also have one, like we have them in our kidneys as well. And these will move drugs into the urine that maybe couldn't have via glomerular filtration. And then we have something called pH-dependent ionization. This is kind of just a little side note. So acidic drugs ionize in basic urine. So they cannot be reabsorbed back into the bloodstream, so therefore they are excreted faster. And this is incredibly useful for to take into account when somebody has overdosed. So for example, aspirin poisoning. Aspirin is very acidic. And so when your urine is basic, basically you can alkalinize. Your basic urine is going to trap the aspirin so that it won't be reabsorbed and it can be excreted so that you can get rid of some of those toxic effects of aspirin poisoning. We kind of talked about the two conversion processes. So what happens in the liver, glucuronidation. This whole course is a struggle of big words, let me tell you. So that glucuronidation converts lipophilic into hydrophilic, so it can be excreted. And then in the kidney, we have pH ionization, less reabsorption, more excretion. Some non-renal excretion would be breast milk. So lipid-soluble drugs can pass into breast milk, So therefore, it's really important for anybody to avoid unnecessary drugs or medications while they're nursing. Some other routes are bile. We talked about enterohepatic recirculation, the lungs. So when we're way later on, we'll talk about anesthetics, and that would be lung excretion. And then it can also occur in sweat, saliva, and expired air. So kind of the last thing to talk about with pharmacokinetics is the time course of drug response. So administration, distribution, metabolism, and excretion all determine the onset, the peak intensity, and the duration of effect. So when we're talking about plasma drug levels, you have something called the minimum effective concentration. This is the lowest level for therapeutic effect. Basically, like the lowest drug level one would need for therapeutic effect. We have toxic concentration, and this is where adverse effects will begin to happen. And the therapeutic range is between the minimum effective concentration and the toxic concentration. So it's that little window of area, and that's where we will be dosing, basically. So if you have a wide range, a wide therapeutic range, it means a safer drug. So for example, Tylenol has a wide range, and that's why you can get it over the counter, stuff like that, because it's relatively safe for somebody to take without, there's direction on the box, but without clear direction and monitoring. But if you have a very narrow range, if there's not a lot of difference between the minimum effective concentration and the toxic concentration, that's when drugs can become very unsafe and require monitoring. So an example of this would be lithium. It's very easy to get lithium poisoning, and so whenever lithium is administered, you definitely want to be monitoring that patient. There's always a delay before effect, and that is categorized in the absorption time. So the rate of absorption will equate to the delay before the effect of the drug begins. And then the duration, you can measure duration by the rate of metabolism and excretion. So once that drug is metabolized and excreted, obviously you're not going to be feeling the effects of it anymore. So that's where duration ends. And then we have drug half-life, which I've kind of talked about, mentioned. So basically, it's the time for the concentration of the drug to drop by 50%. So the shorter the half-life, the more frequent dosing one needs. The longer the half-life, the less frequent dosing. And then drug accumulation. So when you give repeated doses, drugs can accumulate until they reach a plateau or a steady state. And the definition of a plateau or steady state is when the drug being dosed is the drug being excreted. So drug in equals drug out. And for generalization purposes, we say it takes approximately 4 half-lives to reach a plateau or to eliminate a drug after stopping. And again, every drug is different. This is very generalized. Some drugs it takes can take up to a month to reach a steady state. Some drugs, it can take up to a month to actually get it fully out of your system, because if you think about it, the first half of the drug, so say after 24 hours, you get rid of half the drug, that's great. Another 24 hours, half of the half, so that's a quarter of the drug. But as you get into the smaller percentages, it's going to take a lot longer for them to be excreted. And when somebody's chronically on a medication, we want to reduce fluctuations in the amount of drug in the body. So in order to do that, we can do continuous infusions, we can do depot preparations, and we'll adjust dose size and interval to best accommodate for how the drug reacts in the body, meaning like plateau and steady state. And then also, if a drug does take really long to reach that half-life, we can do something called a loading dose, which is that very large initial dose so we can reach plateau faster, and then the maintenance doses are just the smaller ongoing doses to sustain that plateau. So that finishes up pharmacokinetics. The big things to remember is the differences between absorption, distribution, metabolism, and excretion, and also how the drug levels fluctuate in the body. So that is our pharmacological story for pharmacokinetics, and I'll see you next time.